While we're passing the clicker, let me just brag on Dr. Kronick and AHRQ's behalf. Is this on? Okay. That evaluation of the Partnership for Patients that you just heard about, I happened to learn yesterday quite serendipitously. You know the Glenn Kessler, the fact checker, he apparently grilled their team for over an hour and gave them zero Pinocchios, which means that you get believe it's called a Geppetto check mark. I thought Rick might be too tasteful to mention this himself, so Dr. Kronick.
Well, thank you, Carolyn. It is a great honor to be able to represent AHRQ at this symposium. The reports Crossing the Quality Chasm to Err is Human have had profound effects on the work that we have done at the agency over the last 15 years. There's been, a lot of discussion this morning of the importance of culture, and that errors and quality is a system issue and not a bad apple issue, and that has influenced our work greatly. I've been, as Carolyn said, a director at the agency for about 2 years, and when I got there, I was not able to give a crisp description of what we did to make care safer and improve quality. And this is despite the fact that I had been at ASPE for 3.5 years. I spent 25 years in health services research. You all are probably as knowledgeable about the agency as almost anybody in the country, but I can imagine that you may be in a similar position, and I'm hoping that in 3 minutes and 50 seconds from now, you will be in a different position. So what do? We do 3 things at AHRQ. We invest in research and evidence to figure out how to make healthcare safer. There was a lot of discussion earlier today about the need for the kind of engineering part of what needs to get done to improve safety, both at the technical level and at the level of changing culture. Evidence in and of itself doesn't do anything to lead to improvements. The evidence needs to be understood and used. And the second thing we do is invest in materials to teach and train, to catalyze improvements. And the third, and there was discussion this morning also about metrics and the difficulty of metrics, but we invest in data and measures to be able to figure out how we're doing, where further progress needs to be made, feedback to providers and patients and policymakers. So that's kind of a high level, 3 things. Well, what does that mean? I want to give the example that Patrick has already mentioned as an example of how each of these 3 things has contributed to progress. So as Patrick mentioned, we issued a report last week showing that from 2010 to 2014, the rate of adverse events in hospitals declined by 17%. So in 2010, there were 141 adverse events for every 1,000 hospitalizations. That rate declined to 121 by 2014, so from 145 to 121. There was a lot of discussion earlier this morning about measurement. These estimates come primarily from chart reviews of about 30,000 medical records using the standardized protocol each year. And so we're pretty confident of that 17% increase in safety. We're looking at 28 different kinds of adverse events: central line infections, catheter-associated urinary tract infections, falls, pressure ulcers, adverse drug events, et cetera. We then have estimated, as Patrick said, 87,000 fewer patients dying as a result of this 17% improvement in safety. 2.1 million fewer adverse events, about $20 billion in cost savings. And in 2014 alone, 37,000 fewer deaths as a result of that 17% improvement in safety, about equivalent to 1 year's deaths from breast cancer in the United States. Clearly, 121 per 1,000 is still way too high. Lots of work to be done, but substantial progress has been made. The important question, I think, then is, well, why did this happen, and what do we need to do to go from 121 even further down? A multifactorial answer, as in all work in safety. Why did it happen? I mean, at one level and most fundamentally, the hard work of hundreds of thousands of people in hospitals all around the country, almost certainly catalyzed by the Partnership for Patients effort that Patrick mentioned, that was conceived and championed by Don Berwick when he was administrator. And I can't emphasize enough the difficulty of getting all the various parts of HHS and the White House to agree to a $500 million plus initiative to improve safety. And Don's work was instrumental in that. But fundamentally, this progress also reflects each of the three kinds of things that AHRQ does that I talked about on the last slide. I'm going to go through this very quickly. First, the investment in research. Many years ago, Peter Pronovost did the research to show how to reduce central line infections, and this has been discussed already today. I will point out only that in 2014, central line infections were down 70% from 2010. So 0.15 CLABSIs per 1,000 hospitalizations, not quite at zero, but definitely getting in that direction. Lots of other research that we have invested in to figure out how to make healthcare safer. The tools and training part, CUSP was mentioned earlier, this comprehensive unit-based safety program. We have created patient safety culture surveys that are used by thousands of hospitals around the country. The team steps, important work on figuring out how to communicate better, various tools and training work, and then the investment in measures and data. So how do we know that we went from 145 to 121? Well, it's because we have invested in a system to do that. And more importantly, what's underneath that? How are we doing on falls, on pressure ulcers, on adverse drug events? Where do we need to be making further efforts? A variety of other investments here, importantly, the National Healthcare Qualities and Disparities Report. Where are we going? How do we make further progress? I mean, we need to continue to work on improving safety in hospitals, as Patrick and I have each said, and others have said, 121 adverse events per 1,000, while progress is still way too many, and we are continuing to invest there. Most of our work and most of the work in the field has been focused on inpatient hospital safety, and we have, over the last a couple of years, expanded our investments into ambulatory care and long-term care settings. Carolyn mentioned the IOM report, excuse me, on diagnostic errors, which we were very proud to help support. We have funding opportunity announcements out in these areas and are reviewing some good applications now and are looking forward to many more in the future. So I'll close by saying that the elephant in the room, or maybe more accurately, the elephant in the rooms down on the other end of the mall, is support for this work. And we are hopeful of sustained support, but that's clearly under attack as we speak. So I look forward to the discussion to come. Thanks.
Thank you.